So next is live kidney donation, and it's V8. 35-year-old woman with end-stage renal failure who has been active on the cadaveric renal transplant waiting list presents to the transplant clinic with her husband as a potential live donor. She is medically fit and well. 40-year-old man. Apart from a history of hypertension, how would you proceed with your assessment of the donor? So obtain a full history, risk factors for future development of renal disease, exclude any potential transmissible disease, fitness of donor for surgery. Hypertension is a risk factor of CKD and precludes organ donation if there is evidence of organ damage like left ventricular failure, hypertrophy, or proteinuria, or potential donor is on more than 2 antihypertensive agents. BMI if more than 35, absolute contraindication to donation. General examination and do the labs, urine, FBC, UEs, LFTs, CA, coagulation, fasting glucose, hepatitis B, C, HIV, CMV, EBV, and syphilis serology, and urine protein creatinine ratio and MSU, chest X-ray, ECG, echocardiogram, rule out left ventricular hypertrophy. If these investigations are satisfactory, I will then arrange renal ultrasound scan to look for presence of 2 renal kidneys, isotopreniogram to check individual kidney function, and CT angiogram to delineate the renal anatomy. Urinalysis reveals microscopic hematuria, but all of the tests are normal. What would your next course of action? All potential donors with hematuria should have cystoscopy if no cause is found. Then assessment otherwise normal. The potential donor should have a renal biopsy to rule out the glomerulonephritis. All investigations are satisfactory and you can find the donor suitable to proceed pending review of the S-tube scan and CT angiogram. The S-tube scan reveals equal function in both kidneys. The CT angiogram reveals a single renal artery and vein on the right, but 2 renal arteries and 1 vein on the left. How would you proceed? So, the result could be reviewed in multidisciplinary meeting. Left kidney with 2 arteries is usually still preferable to a right kidney with a single artery unless there is a significant difference in the divided function. This is due to the fact that the renal vein is longer, facilitating ease of implantation. However, choice of kidney for donation remains for discussion between both the receiving and implanting surgeons, with various risks and benefits discussed with both patients if possible. Multiple arteries are usually reconstructed prior to implantation to allow for a single arterial anastomosis. Thank you.